Thanks for having me. So as Carol said, I'm going to present the key finding of the girls' questionnaire. So here's the plan of my presentation. We will first talk about generalities about the questionnaire, then focus on epidemiology of the patients who are described here, then diagnosis, symptoms, other health problems, evolution, and a quick talk about school to finish with. So, as Carol just said, the questionnaire was sent to all the families with CTD girls. We obtained 21 responses, which was a very good score considering the number of families with CTD girls described in the world. The questionnaire was anonymous and mainly completed by mothers, and it was translated in 4 languages, which were French, English, Italian, and Netherlands. We obtained a population for whom mean age at the questionnaire response was 18.8 years old, ranging from 3 years old to 48 years old. And mean age at first symptoms was 1.8 years old. Mean age at CTD diagnosis was 11.8 years old. And so we can here notice that there is a big gap of time between the age of CTD first symptoms noticed by parents and the age of diagnosis. On this graph, and as Aurore said this morning, we can see that blue dots represent the age of CTD diagnosis for those who are 18 years old and older. And on the red dots, you have the age of CTD diagnosis for those who are 18 years old and younger. And we can see that for the younger girls, the diagnosis was made younger, suggesting an improvement in the time of diagnosis. If we have a closer look at the symptoms noticed by parents before diagnosis, we can see that there are a lot of them. I'm not going to cite them all, but we can say that they are ranging from global to specific developmental delay, relationship issues, motor difficulties, behavior problems, epilepsy, sleeping disorders, not feeling the pain. And the 3 most frequent symptoms were speech delay, developmental gap with other children, and motor skills difficulties. So what is important here to notice is that none of these symptoms are specific, and therefore it leads to a lot of diagnosis wavering for the families, with mostly 2 diagnoses that were set to parents before CTD, which were autism spectrum disorder and psychological problems. As we said before, there is frequently a big gap of time between the first symptoms and the diagnosis. And during this lap of time, most of the parents try to get an appointment and try to understand what happens with their daughters. But usually, just having an appointment as the first step is difficult. And for at least half of the patients, this was the first difficulties in the diagnosis. Different professionals are included, such as pediatrician, pediatric neurologist, geneticists, or psychiatrists. And once again, as we're going to say, there is the exams that were made to confirm the diagnosis, all the girls did not get the same, and so for a bit more than half of them had creatine level in the blood, some of them had creatine level in urine, some of them had an MRI to assess the creatine peak in the brain, but the diagnosis was confirmed for all of them with DNA analysis, finding a pathogenic mutation in the gene. After the diagnosis, let's talk about the symptoms, and first of all, we're going to talk about epilepsy. 12 girls reported having epilepsy, which was 57% of the described population, which is the same numbers as we said this morning, and various symptoms were reported for epilepsy. All types of epileptic symptoms were reported, as we can see on this graph, such as convulsive seizures, language alteration, chewing, etc., but the most frequently described symptom by parents was absence or alteration of consciousness. We can say that for most of the girls, for 9 girls, there were multiple types of epileptic fit and symptoms, and just for only 3 of them, we had only absence or alteration of consciousness. To treat this epilepsy, different treatments were tried. On this graph, you can see on the blue bars the number of patients who received one treatment, and the yellow bar represents the number of girls for whom the treatment was effective. Of course, we cannot conclude because the sample of patients is very small, but we can still comment and say that lamotrigine was the most frequently tried treatment, and it was effective in most cases for 4 girls out of 6. But other treatment shows effectiveness as carbamazepine, clobazam, levetiracetam, etosuximide, oxcarbazepine, and cannabidiol. Some treatments were tried and showed no effectiveness, such as sodium valproate, clonazepam, and lacosamide. We were not able to make a correlation between the type of epileptic seizure and the treatment that was tried because of the small sample and because we had not so many information about that. And we can also say that 6 patients received creatine, arginine, and glycine supplements to try to treat epilepsy, but this was effective for only 2 patients out of 6, inducing a diminution of the epileptic episodes. As we said before, one of the most frequent symptoms that was described by parents is a gap between the development of the girls and the development with other children. So a lot of questions of the questionnaire try to describe the main developmental milestones of these girls. We chose 3 of them on these graphs, and so we chose sitting without support, walking age, and making 2 or 3 word sentences. For the 2 first graphs, sitting without support and walking age, we can say that at least about 60% of the described population acquire these skills at the same age as general population. So we can see that sitting without support is acquired for the described population for 60% of the girls, and it's the same for walking age, because before 18 years old, we have at least 60% of the population who can walk without help before 18 months old. But the most difficult task for these girls was talking, because 2 or 3 word sentences was usually acquired later. And we can see that before 3 years old, only 40% of the girls can make 2 or 3 word sentences, and that it could be sometimes acquired very late compared to general population. We're going to talk a bit more precisely about development, and we chose to develop 4 domains, which are autonomy, motor skills, learning skills, and socializations. So all the results are going to be presented on these graphs like this, where you have on orange the number of patients for whom the task is learned, in yellow the number of patients for whom the task is being learned, and in green the number of patients for whom the skill is not learned. We just have to remind you that the mean age of these patients was 18 years old, and that we excluded for some skills the girls who were too young to acquire the skills. So if we talk about autonomy, all girls have learned some skills, but we had very different profiles, ranging from complete autonomy for 2 girls to needing help for basic tasks such as eating or getting dressed. All of them can dress themselves alone and eat alone or just with a little help. 18 declares being dry during the day, 17 declare being dry during the night, and 2 of them, as I said before, declare being completely independent. The most difficult skills were complex tasks, such as taking the public transportation, preparing a meal, and going to the store alone. If we have a closer look at motor skills, we can say that running, jumping, throwing a ball, and climbing stairs was learned for most of the girls too, as we can see on these bars. And the most difficult tasks were the one including fine motor skills, such as tying shoelaces or opening a door with a key. And other difficult tasks were the one including coordination skills, such as swimming, riding a bike with no training wheels. As we described before, learning skills were very different from one girl to another, so I'm not going to cite all the skills that we asked the families about, but to sum up, we can say that simple skills, such as understanding yes, no, basic instruction, counting up to 10, was learned for the majority of the girls, as we can see here. But concentration seemed to be difficult for more than half of the population. And for all the other skills, such as reading, writing, drawing, reading the clock, etc., the level was very heterogeneous from one girl to another. To finish with this graph, we're going to talk about socialization skills. Once again, the level is very different from one girl to another, but we can observe that this is the domain where the patient have the most difficulty. Less than 1/4 of them reported going spontaneously to others, or making friends, understanding social norms, or managing the emotions in public. And this is where this is interesting, because we can understand why autism spectrum disorder is frequently mentioned before the diagnosis. More or less, one turn can play with other, participate in a conversation, or give her opinion. And it's also important to notice that apart from going to others, it's difficult for at least half of the girls to make themselves understood by others. So this is also another difficulty. Sorry. Then we're going to talk about behavior issues. So behavior issues were frequently described by parents and concerned 15 girls of the described population, which was 71%. These issues could be very different from one girl to another, including aggressiveness, screams, jealousy, verbal violence, etc. But the three most frequently described by parents were frustration, screams, and aggressiveness. Other health problems were frequently described. And in the first place, we had gastrointestinal problems for 10 patients, which was half of the described population. Chronic constipation seems to be a very frequent issue for these girls. Once again, anxiety and frustration is a daily life problem. And other health problem was really anecdotic and was from concerning every time just one girl, such as scoliosis, chronic headache, polycystic ovary syndrome, etc., etc. As we just said, the range of symptoms varies from very mild symptoms to very severe clinical presentations. And once again, the evolution over the years is very, very different from one girl to another. And in the past years, 1/3 of the families declared that the symptoms were stable. For 1/3, the symptoms had worsened. And for 1/3, it was a good evolution over the year. So evolution does not seem to be predictable. Finally, quick talk about school. As we just exposed, girls with CTD can have very different symptoms and profiles. Therefore, this means that they all have different needs, and schools need to adapt to every girl and every profile that they have. Because they came from very different countries, it was sometimes difficult to compare exactly the scolarities, but we can say that levels was ranging from preschool to high school. Some of them had inclusion with support, some of them attended special needs school, some of them had individualized education plans, and some of them were not at school, usually by choice of parents. So finally, we can say that girls can be affected by CTD with a very various symptoms, a range of severity that is very large, and different evolutions. Thank you for your attention.